Welcome to you all who have joined us today to participate in this historic recording of the module iteration of number 1 that we will be presenting to you today. It is the module number 1 is the introduction to chronic kidney disease, an overview of causes, staging, and treatment. And I am Leslie Dinwiddie, project leader and the author and presenter of this module 1. These modules were designed to tell about the nursing care of our CKD patients in other settings, any setting. And it's most important that we emphasize that we are partnering with you and those others who are taking care of our patients for quality care. These modules are dedicated to the memory of Sally Burroughs Hudson. She is a past president of the American Nephrology Nurses Association, ANNA, and she's a fierce proponent of the continuing education for all nurses. She would be so pleased to know that of the recordings that we've had over the past 10 years, we've had 11,000 views of these modules, most of which have been for module 1, but it has been delightful to know that the stages described in modules 2 and 3, as well as palliative care of our patients, have been very, very popular. And now on to module 1 and chronic kidney disease, causes, staging, and treatment. First, I'd like to give you a brief history of kidney disease and its treatment. Up until this time, 1945, kidney disease was a fatal disease. There was no treatment. But back at this time, in 1945, we knew that with the introduction of a crude hemodialysis system, it allowed a 7-year-old a patient with acute kidney injury to survive. And also that year, there was a peritoneal dialysis patient who recovered from acute kidney injury after 7 days of continuous dialysate flow. Not too many years later, 1954, we saw the successful transplantation following donation of a kidney from a twin, an identical twin. And that led to the science of tissue matching and immunosuppression to prevent rejection, and is still today the most successful treatment that we have for chronic kidney disease and kidney failure. Now, the problem that we had early on with hemodialysis was that we had to continually access the blood system, and we were wearing out vessels. So in 1960, along came the Scribner arteriovenous shunt, and that made long-term dialysis possible for the patient with chronic kidney disease and kidney failure. Another type of vascular access shunt was the arteriovenous fistula that Brescio and Cimino invented and trialed in 1967, and is still one of the best accesses today. The early successes that were achieved just led to huge challenges of supply and demand. All of a sudden, there were so many patients who needed this, so that in the 1960s, they convened death committees to determine who would receive these life-saving treatments. It was an exciting but difficult time for our patients and our interdisciplinary team taking care of them. A lot of nurses began specializing in these treatments, and in 1969, ANNA was formed because these patients were critically ill and required our nurses to have specialized skill. The big breakthrough because of the demand and the challenges came in 1972, when Congress voted that CKD should become the first and only disease to qualify as a disability covered under the Medicare program. That led to an explosion in scientific research and expansion of the kidney replacement therapy industry, such as we have today. And it also led to this becoming available around the world. And in the 1990s, we were getting data from international outcomes that led to clinical practice guidelines development. More about that later. But the next big shift that we saw was in 2020 with the pandemic of this novel virus, COVID, that led us to focus on acute kidney injury and increased the need for the safety of self-care dialysis at home. What we learned from Rembrandt was that if you practice what you know, it'll help make clearer to you about what you now do not know. And that was certainly the story of us developing treatments and better outcomes for our chronic kidney disease patients and our kidney failure patients. So I have specific objectives for this module. I hope that at the end of this session, you will be able to define chronic kidney disease and list the major causes. And you'll be able to list and describe the stages of chronic kidney disease from both onset to kidney failure. You'll be able to describe the major complications of chronic kidney disease and kidney replacement therapy and discuss the broad demographics of the kidney disease population. I think the best way to get this started is to give you a very brief review of the anatomy and physiology of the kidney. Kidneys are highly vascular organs that weigh approximately 120 to 160 grams. That's 4 to 5 ounces in each, and that's in the adult. Kidneys are located in the retroperitoneal space. The right is slightly lower than the left, and they can have one or more renal arteries. These kidneys receive 20 to 25%, about 1,200 mils per minute of the cardiac output of oxygenated blood. And this blood is all taken into the kidneys and to the approximately 1 million nephrons. The blood vessels, the efferent arteriole, goes into Bowman's capsule and exits out the efferent arteriole that then wraps around the loop of Henle and joins up to become the efferent venules and go out through the renal vein into the inferior vena cava. So the glomerulus is all important to this discussion. It's a vascular complex of capillaries that filter the blood. And as we just said, it filters up to 125 mils per minute of plasma. Urine that results from this filtration is normally between 1.5 to 2 liters per day. And that urine exits each kidney via a ureter into the bladder for excretion from the body. But what's absolutely important to know is that while the anatomy is highly complex, so is the physiology. And these kidneys are critical for normal homeostasis. The main functions of these kidneys that are critical for normal homeostasis is the regulation of both the body fluid volume and osmolality. It also is in the kidneys that electrolytes and acid bases are balanced in these bodily fluids. Blood pressure is also regulated through the kidneys, as is red blood cell production in the bone marrow because of erythropoietin. The kidneys are therefore responsible for excreting metabolic wastes that the body no longer needs, and especially drugs and toxins that are going to harm the body if they stay. The synthesis of erythropoietin for new red blood cells was something that was not known before we knew about chronic kidney disease and could have patients who would survive kidney failure. Renin as well, with hypertension, was identified. And the influence of vitamin D on the mineral aspect of blood for our bones and bodies became also very important. And we also know that the kidneys are very important for gluconeogenesis. And that was quite a surprise to the scientists. Now, a single healthy kidney, even though we have two, can maintain normal function in the event that a person is born with a single kidney. That's called unilateral agenesis. Or if a person has had to have a kidney removed due to severe trauma or cancer. Or this is a patient who has kidney failure and receives a kidney transplant, but also for the donor who gives that kidney. They can survive very well with one kidney. The major categories of kidney damage dysfunction that we're going to discuss today are both acute kidney injury and chronic kidney disease. This has become, as I said earlier, with the pandemic, we saw a rise in acute kidney injury, and it was something we'd been dealing with for years, but it is the abrupt loss of kidney function that results in all of the things that happen when we no longer have the abilities of the kidneys. So we're going to have retention of urea and other nitrogenous waste products, and we're going to have dysregulation of the extracellular volume and electrolytes. This got more and more attention in the early 2000s after we came up with after the Kidney Foundation came up with the KDOQI guidelines. KDIGO, which is the Kidney Disease Improving Global Outcomes, which is a society of nephrologists from around the world who'd been doing studies for years, and they showed that acute kidney injury had very specific parameters that they could now use as diagnostic parameters. So acute kidney injury is in a patient who has been previously apparently healthy. It's an increase in serum creatinine by 0.3 milligrams per deciliter within 48 hours, or an increase in serum creatinine to 1.5 times that patient's baseline, or a decrease in urine volume of 0.5 mils per kilograms per hour for 6 hours. And I'm sure that you all know that serum creatinine normal ranges from 0.5 to 1.2 milligrams per deciliter. And this was published by KDIGO in 2011 guidelines. We find acute kidney injury most frequently in hospitalized patients who've had severe trauma, such as hemorrhage, severe hemorrhage, burns, extreme GI losses, and also that have had trauma, nephrotoxicity from drugs or other toxins, and have maybe developed septic shock as well. Sepsis and septic shock does cause acute kidney injury, and these are the definitions for sepsis as well as septic shock. And we know that greater than 1/3 of the US COVID-19 hospitalized patients developed acute kidney injury, with around 15% requiring emergency kidney replacement therapy. So the staging that KDIGO came up with for acute kidney injury was looking at these three levels of both serum creatinine and the urine output. And it was amazing that it could be dropped so quickly, so fast, from 6 to 12 hours to less than 0.5 mils per kilogram per hour for 12 hours or more, and then down as far as low as 0.3 mils per kilogram per hour for 24 hours or more, or not having any urine output for 12 hours or more. So the treatment that had to happen was critical care hospitalization, may require kidney replacement therapy, as indicated, including acute hemodialysis, or continuous kidney replacement therapy, as indicated. And both of those treatments require vascular access. Acute peritoneal dialysis, of course, requires peritoneal access. But what is important to know and remember about acute kidney injury that wasn't fully appreciated until the 21st century was that a patient who had had acute kidney injury was now at risk for chronic kidney disease, even if they appear to have recovered, and that those who have chronic kidney disease are also at risk for acute kidney injury. And there's a number of risk factors that you'll see on the far left of the screen, both their age, race, genetic factors, hypertension, diabetes, metabolic syndrome. And then there are those disease modifiers that you've got to consider: the severity of the AKI or the stage of the chronic kidney disease and how many episodes they've previously had, as well as how long they suffer the acute kidney injury and do they have protein in their urine. And of course, the outcomes that we would hope for is that, or that we would not hope for, rather, excuse me, that there would be increased cardiovascular events, end-stage renal disease or kidney failure, disability, and diminished quality of life, and hopefully not death. So let's switch to chronic kidney disease, and KDIGO has a definition for that as well, according to their guidelines that were started in 2012 and updated in this very year, 2024. Chronic kidney disease is abnormalities of kidney structure or function that is present for more than 3 months with implications for health. And CKD is classified based on cause, GFR category, and albuminuria category. And you'll see us call that the CGA. So they have this interesting graph for the prognosis of CKD by GFR, that's the glomerular filtration rate, and albuminuria categories. And this will also introduce you to the nomenclature that we use for this staging. You'll see down on the left side the GFR categories. Now, I've got to give you a little more history here. Back in the 1990s, the National Kidney Foundation began understanding that there was a wide variety, and what we only used to have 2 categories. We had what we called chronic renal insufficiency, a term we no longer use, and we had end-stage renal disease, which we now call kidney failure. There were only 2 categories that we understood, and they realized that what we needed to do to be able to diagnose, treat, and hopefully prevent progression of chronic kidney disease, we had to be able to stage it. And the way they originally began the staging was to look at the glomerular filtration rate. And they came up with these 5 stages on the left of the blue area, G1 to G5, and there's actually 6 stages because stage 3, and I'll get into that more in just a little bit, they went from normal or high glomerular filtration rate, greater than 90, down to kidney failure, which was a glomerular filtration rate less than 15, and then everything in between was divided by 2 and 4. Then with Kadigo's work later and published in 2012, they then knew that persistent albuminuria was a very, very important part of the severity of the chronic kidney disease. And you'll see this very colorful variation in the graph here from the normal or mildly increased in green, and then varying from the yellow through the orange through the red. At the very bottom, it becomes very red to show the increasing severity based on albuminuria. So that's where they came up with the CGA name for the staging. So the definition of glomerular filtration and its calculation is what we will get started with here. So normal glomerular filtration rate is 125 mils per minute. But by the time you get to be age 30, you are starting to lose 1% per year. So old age is one of the considerations for a lower glomerular filtration rate. And in the past, we used to measure GFR with a 24-hour urine collection. Fortunately, we don't have to do that anymore because they were highly unreliable. And a much more reliable estimation of GFR in adults is a calculation that uses a serum creatinine, age, and gender. And this is the EPI equation, and it can be found with other discussion of this on the National Kidney Foundation's website, and they provide calculators for these equations. Now, Kadigo this very year came up with this very nice graphic for helping us understand the complexity of the diagnosis and staging of chronic kidney disease in adults. And you can see that male and female, it's the same, whether it's for male or female. And I'm not going to go through these, but it is basically how the interdisciplinary team would evaluate the causes of chronic kidney disease. They also came up with this very nice schematic for the staging and how to identify adults at risk for CKD. And you'll see that it takes you through the various steps of what you have to do to determine whether this is AKI, or if advanced AKI is considered acute kidney disease and failure. Then on the left, you'll see that the diagnosis through GFR, and on the right, where it's determined that GFR above 60 with less than 30 milligrams per gram per millimole shows that CKD is not present. What becomes very interesting in discussion of CKD is how very little is known in the general population about chronic kidney disease. And what we know from our studies about the prevalence of chronic kidney disease. Basically, and this is NHANES data cited by the Center for Disease Control and Prevention this past year, it shows that there are more than 1 in 7 US adults, that's 15%, are estimated to have chronic kidney disease. That's about 37 million people. That's a lot of people. But 9 out of 10, and this is what is shocking, they do not know that they have chronic kidney disease. What we know is that it's more common in people aged 65 years or older, 34%, than in people who are middle-aged, that's 12%, or the younger people, it goes way down to 6%. Interestingly, women have it more frequently than men, but not by much. But we also know, and I'll be discussing this more in just a little bit, is that it's the non-Hispanic Blacks who are in the majority, then the non-Hispanic Asian adults and non-Hispanic whites are 12%, and about 14% of Hispanics have chronic kidney disease. So let's talk about a little bit more about the incidence and prevalence of diagnosed chronic kidney disease and kidney failure. We've already said it's both underdiagnosed and undertreated, though, because it's underdiagnosed. And we know that 35.5 million US residents suffer from chronic kidney disease. 14% of adult patients in the US have a diagnosis of chronic kidney disease. And for stage 5 kidney failure, the progression to kidney failure, the incidence, the most recent data that we have from the United States Renal Data System shows that we had 136,000 patients, more or less, diagnosed with kidney failure. And what is shocking is that less than a third of those had 6 months of nephrology care. The prevalence of population in 2021 on the last day of the year of kidney replacement therapy was 808,500 patients. We further know that while they say there's gender equivalence in kidney failure, it is males that have 61% of kidney failure. And I told you we're going to talk more about the significant disparities between race. While Caucasians, white patients, are the majority of the patients, Black and those African-American patients have the highest rate. They have 4 times the rate of white patients with kidney failure. And it's because of the low numbers of Native Americans and Asians due to minority status in the United States, that equals lower prevalence, but it's still twice the rate of white patients. I'm delighted to say, though, it's our pediatric patients less than 18 years who have the lowest kidney replacement therapy prevalence. We had just 5,500 pediatric patients in 2021. And of those, I'm delighted to say also, 76% had transplants as their kidney replacement therapy. Now, this is an interesting graph from the 2021 USRDS data published in 2023, that if we looked at the incidence of kidney failure by primary diagnosis, you can see that diabetes is way, way out there in the majority, followed very slightly by hypertension, and together they make up a huge proportion of the patients who are starting kidney replacement therapy. You will also see that most of them get started on in-center hemodialysis. That's in the blue bars. And very few are in the self-care or preemptive transplant category. Good news is that changes with the prevalent data. But let's talk a little bit more about the major causes of kidney failure. Over there on the right of this circle, you can see the huge number that have diabetes. It's 44% of the incident population and drops to 37% of the prevalent population. And second is hypertension, 29% incidence, 26 prevalence. But there is another major category that's well worth looking at, and that's that one down in reddy orange on the bottom right, the glomerulonephritis. These are the long-term survivors of and who've been able to be treated and don't have the other risks that the diabetic and the hypertension patients have. So patients with cardiovascular risk are at risk for chronic kidney disease, and those with chronic kidney disease are at risk for cardiovascular disease. You'll see that there are other causes of chronic kidney disease that are fairly rare, inherited disease, autoimmune disorder, but we also need to discuss nephrotoxic damage from drugs such as NSAIDs, ibuprofen, radiopaque dyes. I think that has decreased a lot since we've known about it and been able to control it. Then there's environmental contaminants that I'm sure is going to become more and more apparent over time, and other toxins that the human body is exposed to and needs to get rid of via the kidneys that can cause some damage. So let's go back to the staging of chronic kidney disease from beginning to kidney failure. This again is from the latest KDIGO report in 2024. And you'll see that it looks very much like that graph I showed you before, except we've got a whole lot of numbers and words in the colored part. And again, CKD is classified based on cause is the C, GFR is the G, and albuminuria is the A. We started again with the National Kidney Foundation with GFR, but what we found with the KDIGO report is they now have come up with a way of shading this graph to show severity and the need for more frequent testing and treatment. And those in the dark red at the bottom are the ones who are very, very high risk for kidney failure and needing kidney replacement therapy. This slide shows more clearly the kind of GFR correlated with their risk and potential for progression, and shows the treatment times, how often they need to be monitored and treated. And most especially important here is to show that when you get to stage 3, you really do need to refer to a nephrologist to be monitored 3 times a year. And that is extremely important, as we'll discuss on each of the stages in the next few slides. So here we've tried to outline the action taken by the interdisciplinary team. The nephrology interdisciplinary team is not going to see these patients necessarily until they get to stages 3 or 4. So it's in the general practice interdisciplinary team that they need to be looking for these stages, chronic the causes and GFR and albuminuria, which makes up stage 1, is in stage 1 going to be greater than 90 GFR or considered normal, especially with age considerations. So at that point in time, probably not going to make a diagnosis unless there's some kidney damage involved that is apparent, or and they will certainly be treating any of those, but treating comorbid diseases also that we know, such as diabetes and hypertension, that lead to chronic kidney disease. And they're going to do this mostly with diet and medication. But it is essential that through every one of these stages, and it should start at stage 1, patient education, and we nurses are the ones that know, have a lot of the responsibility for that. Stage 2 is considered mild kidney damage and albuminuria, where the GFR drops to 60 to 89. And again, evaluation and treatment, monitoring the progression, and more of that good patient education. Now, CGA stage 3A and B, this is kind of a very broad stage. It goes from 45 mils per minute GFR, 30 mils per minute up to 59. So I will have to say there, the signs and symptoms, this is the tipping point for chronic kidney disease. This is where we really have to doing as much as we possibly can to prevent progression. You're going to see emerging evidence of anemia, and this is something new because of the lack of erythropoietin from the kidneys. You're going to see rising phosphorus and PTH levels due to the inability to excrete vitamin D3. And you're going to have difficulty controlling blood pressure because of the decrease of the production, the synthesis of renin. So the action taken by the interprofessional team will be to both evaluate and treat these complications, monitor progression, and definitely at this point, they should be referred to the nephrology team, and certainly lots of patient education at this point. Once they get to stage 4, that's considered severe kidney damage. Signs and symptoms are going to be elevated serum creatinine and BUN. You're going to start seeing signs of metabolic acidosis and mild symptoms of uremia, fatigue, some cognitive effects, lack of appetite. These patients don't feel well by the time they get to stage 4, and they're going to appear pale because of the anemia. They're going to have, as I say, mild symptoms of uremia, impaired cognition, and they are at increased cardiovascular risk. This is definitely a time when you keep nutritional assessment really tight and education so that they can do as well as possible in preventing progression to end stage. But just in case they are going to be winding up in end stage kidney failure, there needs to be education of both the family and the patient and beginning preparation for therapy options in stage 5. Let's talk a little bit more about the uremia. You know, uremia literally means urine in the blood. It's because the kidneys are no longer functioning well enough to get rid of all of those parts of the urine, both the normal physiologic excretion as well as the drugs and the toxins. But these are patients who are going to have, they're going to be very tired and weary and not able to do much of anything physically. They're going to have nausea and vomiting, a really bad metallic taste in their mouth. They're not going to want to eat. They're also going to be itching because the kidneys can't get rid of excess phosphorus. A lot of it is sweated out into the skin, and they become really itchy to the point of damaging their skin. They also may be suffering from some nerve damage and not be able to feel as well in their fingers and their feet. Sleep disorders become common at this time, like restless leg syndrome. And it can't be overemphasized that they're going to have marked cognitive decline because their brains just cannot work as well with uremia. So what can we do about that? Well, we've got to monitor, of course, the signs and the symptoms, the fluid volume. We'll be looking for both the peripheral and pulmonary edema, and we'll be knowing that that's going to result in shortness of breath. We know that they're going to have worsening anemia, because of the lack of erythropoietin, and that they're probably going to have some complications of congestive heart failure with this excess volume and increasing hypertension. What the team is going to be doing, the interdisciplinary professional team is going to do, is if the patient is really suffering badly with all of these signs and symptoms, they're going to begin kidney replacement therapy if appropriate, and we'll discuss that more in a little bit too. They could be doing acute hemodialysis, usually in the hospital, usually with a central venous catheter. They may also be able to do it via acute peritoneal dialysis. And it'd be very rare for them to do a preemptive transplant at this point. But we must also consider that these patients, we need to look at palliative and conservative care, especially for the very, very elderly who have multiple comorbidities and have a very, very poor prognosis. These folks are definitely going to need supportive care, even if it's not kidney replacement therapy. Looking at who is caring for these patients, by the time we get to stage 5, it's going to be nephrology nurses who are going to be doing the most acute nephrology care for these patients. But we only represent about 40,000 RNs in the US, and then we have more than 3 million RNs. And we know that all of these 3 million RNs are going to come in contact with our patients during these early stages of chronic kidney disease, and quite a bit during the very acute phases of stage 4 and 5, and even when we get to having them as on kidney replacement therapy, other nurses are going to be involved. So what we need to be doing in the very early stages with the patient with chronic kidney disease, stages 1 to 4, we're going to be partnering with our patients using the nursing process framework. We'll be looking for those with common diagnoses, the anemia, chronic kidney disease, mineral and bone disorder, dyslipidemias, hyperkalemia, edema and heart failure, hypertension. Those are the people that we're going to be looking for a diagnosis of chronic kidney disease in. And we're going to also recognize them by some of their treatments that are aimed at reduction of cardiovascular disease risk factors. We're going to be helping them with glycemic control, because diabetes being the leading cause of chronic kidney disease. We're certainly going to be helping them with nutrition, fluid balance, and metabolic control to both help palliate symptoms as well as prevent progression. And when it comes time in stage 4, we're going to help them understand kidney replacement therapy. And this is, of course, when they will be referred to the nephrology team. But in all of these stages, and because of how scary these diagnoses and treatments can be, they're going to need loads of psychological support. And we know that we as nurses get to spend more time with these patients, with our patients, than any other member of the interdisciplinary team. So a lot of that psychological support is going to fall to us. What we're going to have is an awareness of the staging of CKD so that we understand that progression of complications and the subsequent treatment these patients will need. And we hope that that will promote your understanding of the nursing care that these patients will need. And I'll say it again, early referral to the nephrology team, patient education on all of the modalities that we'll be talking about in just a little bit. It's especially important, especially for patients that we kind of know are going to wind up on in-center hemodialysis. Those that don't have the ability to care for themselves may not have a donor for transplantation. But in every patient, it's important to preserve their veins. This is so that we can create a really functional arteriovenous access for hemodialysis down the road if necessary. And we're going to have interprofessional as well as interspecialty communication. That is essential. And, you know, we nurses know a lot more about our patients than a lot of the rest of the interdisciplinary team. So we need to speak up with important points about their care and prognosis. In nephrology nursing, we do this with our scope and standards of practice. We also have excellent references and resources that are available to all nurses. Our core curriculum for nephrology nursing, contemporary nephrology, and these practice guidelines that I've been talking about. And of course, for the data, we go to the USRDS. So I want to just break this down and talk about the two most frequent complications of chronic kidney disease, the first of which is anemia. It becomes apparent in stage 3. And our goals of care in stage 3 and further on too, is that we're going to achieve and maintain a good hemoglobin and hematocrit levels within the target ranges so that these patients have the energy that they need. To achieve a reduction in modifiable risk factors for the development of cardiovascular disease, that's why we're going to look at hypertension primarily, as well as dyslipidemia and diet. We're going to have the patient and the family demonstrate knowledge because of our teaching concerning anemia. It shouldn't just be, this education shouldn't just be telling the patients and their family. It should be having them tell you what they understand you have told them about chronic kidney disease and its implications. The specific complications that we are going to look at for anemia is we're going to be looking at the signs and symptoms of anemia, the shortness of breath, the consequences of anemia, including, and this is a huge one, especially in patients who have not had previous treatment and come to us in stage 4, stage 5. They're going to have left ventricular hypertrophy because of the anemia. We're going to tell the patients and family about the diagnostic tests that we use to evaluate anemia and the signs of bleeding, hematemesis, and tarry stools, for instance. We're going to explain to them about the levels of iron and vitamin and the effects on erythropoiesis. And what we do to manage anemia of CKD, both with transfusions as well as drugs to increase their iron levels and erythropoietin. The other major complication we're going to talk about in the goals of care is the complications that are of the mineral and bone disorder. This is where vitamin D3 and that the kidney, normal healthy kidney, excretes vitamin D3. It helps achieve and maintain metabolic bone parameters and acid-base balance within the targeted ranges. And we're going to want our patients to have the strong enough bones to be free of disability related to kidney bone disease. And the pain of kidney bone disease is extraordinary. And we're going to see signs and symptoms of extraskeletal calcification in some of these patients, sometimes in the valves of their heart, sometimes in their blood vessels upon X-ray. We're going to try to reduce modifiable risk factors for the development of bone disease, as well as cardiovascular disease, that are due to this extraskeletal calcification. The nursing care and the assessment and patient teaching revolve around the patient's kidney function and its relation to these disorders of their bone metabolism. And we're going to talk about the consequences of alterations in bone metabolism, and specifically what kidney bone disease is and the symptoms, signs and symptoms of it, and the same for extraskeletal calcification and what it helps promote development of cardiovascular disease. In the nursing care, we're going to look at the signs and symptoms. We're going to look at phosphatemia. Is it high or is it too low? It's usually too high. And hypo and hypercalcemia because of low vitamin D3 levels. We're going to talk about the medications that we give to these patients to control hyperphosphatemia and hypercalcemia. And mostly as it's related to meals, it's very important that they know how to take these meds. It's also very important that we look at their environment and reduce mobility hazards like trip rugs and other furniture that might cause them to trip and to fall and to fracture. We're also going to try and help them get exercise to maintain strength and mobility. And of course, that can range from walking to actual strength exercises and such. And of course, these must all be individually assigned to the patients. So prevention and management of mineral bone disease and extraskeletal calcification is a priority in taking care of these patients and teaching them about what is going on in their bodies. The other major foci of nursing care in chronic kidney dysfunction to do with dyslipidemia and therefore the reduction of cardiovascular disease risk factors, and certainly how they can manage their fluid balance based on their output and hopefully decrease the incidence of heart failure. Nutrition and metabolic control is huge in these patients so that they can avoid the foods that are going to complicate their condition, as well as get enough energy and protein to maintain their bodies. I've bolded both glycemic control and hypertension because it's a reminder that the majority of our patients have diabetes and or hypertension. So we get down to what can we do for these patients who are now in stage 5, which we consider kidney failure. And it used to be that when they got to a GFR level of 15, we'd say, oh, we've got to start some sort of kidney replacement therapy. But really, it's not the numbers that count here. It's how the patient is feeling, how the patient looks, how what's their quality of life. They don't necessarily have to begin kidney replacement therapy when GFR becomes 15. So one of the first options or duties that we have for these patients and goals is to do patient and family teaching that focuses on the 4 treatments available to patients approaching kidney failure. And we put kidney transplant first because I'll tell you a bit more about it in just a little bit, but that is because it is the single most successful treatment for kidney failure, and it is the only treatment that will return them the normal physiology of a healthy kidney. So it's number 1. So we start there. Then we look at self-care home dialysis because we know that self-care and being at home adds a dimension of knowledge and care and better outcomes for these patients, either on peritoneal dialysis, which is mostly done by the patient alone, or by home hemodialysis, which may be done by the patient alone or with a partner. And then, of course, the majority of our patients, and I'll be showing you data on this, are in assisted dialysis, in-center hemodialysis. And last but not least, the fourth option that we're going to be discussing is supportive management and palliative care for those who either choose not to have kidney replacement therapy or who have been on it and wish to not continue it any longer. So preparation for kidney replacement therapy, education is obviously the number one thing that we have to do. And we have to know that they understand a knowledge of chronic kidney disease and both its implications for outcomes and the therapies that they will need to have to get those outcomes. They need to be able to participate in the decision-making process for treatment modality selection, including that transplant evaluation. And every patient must be evaluated for their suitability for transplantation. And we know that it's important that they consider a self-care or home modality if appropriate. And every patient who starts kidney replacement therapy is going to need to be vaccinated to convert to hepatitis B antibody positive status. When I talked about self-care and what patients would choose for themselves, they may be interested to know, and you may be interested to know, what nephrology professionals choose for themselves. This was a study published back in 2010 with interviewing 600 nephrologists about what if you had kidney failure? What therapy would you choose after transplantation or before transplantation if that was your goal? And basically, 90% of them said they would choose self-care dialysis. Now, I know that's because they understand what happens and they want to be in control of their dialysis, but they also know that there's much, much better outcomes for patients who do self-care dialysis. So patient education in stage 4 and stage 5 has to be about preserving upper extremity arteriovenous access sites, mostly veins. We want them to have blood drawn from the patient's hands, the backs of their hands, if possible, because we don't want the superficial veins of both the forearm and the upper arm damaged with a lot of venous access, so that we can give them a functioning arteriovenous dialysis access if the patients are most suitable for and are choosing hemodialysis, whether it be in-center hemodialysis or self-care dialysis at home. And I repeat again, they must be evaluated for kidney transplantation, as that is the very best option. And hopefully they might have a living related donor. I now want to show you some of the data from the latest United States Renal Data System data published in 2023. Basically, incidence and prevalence. As you see here, incidence is when patients are starting for their very first kidney replacement therapy, whether it be in-center hemodialysis on the top, peritoneal dialysis in the gray, a transplant in the green, or home hemodialysis in the red. The other data I'm going to show you quickly is that the number of patients we currently have with these therapies. At the end of the last day of the year, we count all of these patients. And the good news is here, you see this little dip over in the left and the incident where it goes down here. This is because of COVID, and it rose again this is in-center hemodialysis. But what you'll see if you look at the prevalent data is that we have patients still on all of these therapies, but you'll see that transplantation is huge in the overall count. It's more than a third of our patients have functioning kidneys. And these patients, they are doing very well, living very healthy lives. The next category to consider when we go back to total cases, incident cases, we look at that we have very few of the preemptive transplant. We have more on the incident PD, and again in center. And here we are back at, and you'll see the percentages across the bottom and the numbers and percentages across the bottom for all of these patients who are on long-term kidney replacement therapy. This is still the majority, but it's the lowest it's ever been. You look back over the 20 years, it seems like it's increased a lot, but it's the lowest it's ever been. And peritoneal dialysis has doubled, home hemodialysis has doubled in the prevalent population, and transplantation has also doubled over the 20 years. And that's all great news. Let's quickly talk about transplantation, what it is. It's a surgical implanting of a healthy kidney into the lower abdomen. As you can see, there's both arterial and venous anastomosis there, and the ureter goes directly into the bladder. The donated kidney can come from either a living or a recently deceased donor. That obviously is best with a living one because it may start functioning immediately. And this healthy transplanted kidney, the good news is that it restores normal kidney function with all of its physiological benefits that include, going back to employment, having children, having the energy and living the life you want to live. And I remember patients telling me after a transplant, they'd forgotten what it was like to feel good. However, you must remember that transplant is a treatment, not a cure, because the patient must take immunosuppressant medications for the life of that transplant. Those medications have numerous side effects that are getting better, but they're also very expensive. And over time, these patients may get chronic kidney disease again in their transplanted kidney, either from their primary diagnosis or from chronic rejection. And if that's the case, they can go back to considering what is their best kidney replacement therapy. But let's talk about kidney replacement therapy, self-care dialysis. And here we're talking about peritoneal dialysis, which is the most common self-care dialysis and done mostly by the patient by themselves, or home hemodialysis, which is increasing and showing great benefits. But the neat thing is we call this home therapies, but really it can be done anywhere a patient is taking care of themselves in the office, or they could even go on a dialysis cruise if they wanted to. And if they really wanted and are capable of doing self-hemodialysis, it is allowed by Medicare to be done in center. Let's talk a little bit more about what peritoneal dialysis is. It uses the peritoneal membrane to filter out fluid and waste products. It's accessed by an implanted peritoneal catheter. And that can be either a continuous treatment where they're doing several exchanges a day in a 24-hour period, or they can do it at night on a cycler, doing 4 exchanges throughout the night and then maybe having an indwelling during the day. Home hemodialysis, Usually that's a patient taking care of themselves at home, but they may have someone to help them do that, especially with cannulation into the vessels. And some centers require a trained partner to be present during the treatment. It can be done whenever the patient chooses. They can choose to do it 3 times a week for 5 hours duration, or they could do short daily, 5 to 6 treatments a week lasting 2 to 4 hours. Or what has worked really well is nocturnal hemodialysis with treatments lasting over 6 hours, 3 to 6 times a week. These are where we see the best outcomes. The patients can eat normally, drink normally, they just feel better. But the downside is for some patients that home therapies require adaptation of the home environment, both to prevent infection, so we don't want to have pets around, and to accommodate equipment and supplies, and they may not have the space at home to do that. So when we're talking about self-care dialysis in center, as I said, it's Medicare allowed, and there's no doubt that wherever it's done, self-care dialysis increases quality and quantity of life, more partnership, ownership in their healthcare, and that PD and home hemo have a much more flexible treatment schedule so patients can live a much more normal life. Now, in-center dialysis, this is the subject of Module 7. 58% of our population with kidney failure are in-center, so it's still the most common mode of kidney replacement therapy. Their blood is dialyzed at a rate of around 1 liter per 2 to 3 minutes for around 4 hours. They're going to have vascular access to begin the treatment, and it's commonly via either a catheter, central venous catheter, or with an arteriovenous access, with needles. And it's very important to get those central venous catheters out as soon as possible due to the risk of infection, etc. So we really promote surgical arteriovenous accesses. There's no doubt that with a CVC, patients are at increased risk for infection and death, shown very clearly in the data. So with this assisted dialysis in both the chronic and acute setting, you have to have vascular access for long-term dialysis, and that's arterial to a vein. And the majority of these patients are on 3 times a week assisted in-center hemodialysis, some at night, which is great. Let's talk about the fourth option, palliative and end-of-life care for patients with chronic kidney disease. And this is the subject of Module 8. The fourth option is no kidney replacement therapy. This is supportive management with comprehensive palliative care instead. There are lots of reasons that a patient might consider this fourth option, and the family as well. You have to address social, cultural, psychological, spiritual, religious, and physical concerns. There's a lot to consider in either choosing a kidney replacement therapy or choosing not to go on a kidney replacement therapy, but palliative care instead. It's appropriate for patients to do palliative care that have multiple comorbidities, have late-stage cardiovascular disease, and therefore expected shortened lifespans. What we're aiming for here is quality of life. And it's very important to know that nearly 80% of patients starting kidney replacement therapy and 75% on kidney replacement therapy in 2021 were older than 65. So all patients' plan of care should include palliative care and advanced directives, especially if they consider that the time may come that they're not going to want to continue to do kidney replacement therapy and may want to withdraw. And with that in mind, we go to shared decision-making in the appropriate initiation of and withdrawal from dialysis. And this is a wonderful document by the Renal Physicians Association that came out in 2010. They say it's appropriate to forego dialysis for those with acute kidney injury, chronic kidney disease, or kidney failure when these 4 bullets below come into play. When they are no longer, when they are able to make these decisions for themselves and are fully informed, and they make a voluntary choice to refuse or discontinue dialysis. That's very important. A lot of times family don't want that, but the patient does. Previously indicated refusal of dialysis, but these patients no longer can make that decision. Maybe they have irreversible, profound neurological impairment or significant comorbidities, and where kidney replacement therapy would not improve quality of life. And palliative care can provide quality of life for these patients, if not quantity. And I think that's what's most important here. Let's talk in Module 9, we talk about our smallest population, the pediatric population. Fortunately, it's less than 1% of the overall prevalent population, and about 5,500 individuals younger than age 18 who are on kidney replacement therapy. The great news is that 76% of these have a functioning transplant. 12.7% are on peritoneal dialysis and therefore able to go to school and do many other activities. About 12% are on hemodialysis, either at home or in center. The good news continues, knowing that 75% of these patients have had nephrology care prior to kidney failure, and that means that we've been able to slow progression and get them ready for the best kidney replacement possible, and that so many of them have preemptive transplants and so can live normal, active lives that a kid should be able to live. So we know that the extra good news is that incident cases of kidney replacement therapy are decreasing dramatically, down over 10.5% in 10 years. And that's only going to get better. I've told you that we're at 76%, those transplanted. These transplanted kids have a 5-year survival probability of 0.98%. The extra good news is that innovation for their future is exploding. We are seeing wearable and implanted artificial kidneys. We know that they're working on genetically engineered kidney grafts for transplantation. We know that the targeted immunosuppression field is getting better and better. And we know that they don't have to be pulled out of school to keep going to the doctor, because we have telehealth for well visits. So there's a lot more. The future possibilities are endless and exciting. So what we're really looking at here is that this is a very complicated population with a very complex disease, and so has very complicated and complex treatments. And it goes throughout the lifespan. You start with little children, and you go on up through the ages, and you can see with all of these considerations of where they're at in the lifespan, of things that will be happening to them and with them and for them, that these are special considerations and very, very complicated, but I think the future is bright. Again, we have these CKD modules that are listed here with both the dates and the times for future presentation, and will wind up being recorded and put into the ANNA library. Thank you again for your patience with me listening to Module 1 live through this webinar. But mostly, thank you for the care that you give our patients with chronic kidney disease and kidney replacement therapy, and for choosing to learn more about these patients and their therapies through these modules. There are PDFs available online with slide images, a printed narrative, references and resources, and a glossary for all of these unusual terms that you may encounter. I also want to acknowledge the authors of these modules and the reviewers whose expertise is absolutely amazing and so necessary for the care of our patients. And I'm also very, very grateful to have led this project over the years and to be with you through these modules. References and additional readings for those who want to know more. Thank you.